There's a lot happening with New Jersey's child welfare system. We want to help you make sense of it and share our story. This is DCF on the Air.
This is DCF on the Air, and I'm Jason Bukowski. New Jersey, like the rest of our nation, is struggling with a youth mental health crisis that's reached epidemic proportions. A recent report released earlier this year from the Federal Centers for Disease Control and Prevention, covering the years 2011 to 2021, highlights the issue. According to the CDC, 1 in 3 teenage boys and 3 in 5 teenage girls reported feelings of persistent sadness and hopelessness, a marker for depression. Nearly 1/3 of all high school students experienced what could be typified as poor mental health. In 2021, more than 1 in 5 students in this report had seriously considered suicide, and 1 in 10 had attempted suicide. We also know that these challenges affect some groups more than others. Nearly half of students surveyed for the report who identify as LGBTQIA+ had seriously considered suicide, and Black students were more likely to attempt suicide than students of other races and ethnicities. In some of our earlier episodes, we spoke about what DCF is doing to strengthen the youth mental well-being and prevention infrastructure, to offer upstream supports and help children and youth grow in resilience through the acknowledgement of positive childhood experiences. But with national numbers like these, we know we need something more. We need the comprehensive continuum of care from upstream prevention and resilience through to deeper end therapeutic supports. Today, our guest is Mollie Greene, Assistant Commissioner for New Jersey's Children's System of Care, which is the behavioral and emotional health safety net for anyone under the age of 21. Mollie's been with DCF since 2014, and before serving in the Assistant Commissioner position, she had previously served as our Director of Clinical Services, overseeing a portfolio of services connected to health and behavioral health, such as the Child and Family Nurse programs to provide healthcare case management for children in out-of-home care, and the 3 regional diagnostic treatment centers that support the survivors of physical and sexual abuse. Since becoming Assistant Commissioner, Mollie has helped to modernize our system. At the start of the pandemic, and facing an austere state budget, Governor Murphy invested more than $100 million in new funding into stabilizing our system of care. And without that investment, we might not have had the infrastructure to respond to the current crisis we're seeing in behavioral and emotional health among adolescents and young adults. Mollie, welcome to DCF on the Air.
Thank you so much, Jason.
So as we begin today's conversation, I spoke about what the youth mental health crisis looks like on the national stage. Do we have any data about what it looks like here in New Jersey?
So as you mentioned, the Children's System of Care, or CSOC, which is the acronym we use to shorten the name for the system of care, is New Jersey's public behavioral health system for children and youth under the age of 21 who are presenting with moderate to high clinical needs. And so we don't have the data on all of the services that are being provided by outpatient systems. We don't have the data in our system regarding emergency room visits, although we have access to that through DOH.
Yeah.
I do think that what we see in the utilization trends over the last few years is a good marker for what we are probably seeing across the system as a whole. Okay. And so we have seen since about 2015-16 in all of our community service lines a 20 to 25% growth over the last several years. But in particular, as I think folks would not be surprised, we saw a sharp decline in the demand for services in 2020, and then an increase in demand in 2021, which was surpassed in 2022, during which we served almost 75,000 youth and families in the last calendar year. When we look at where we were this spring, in March of this year, we served more than 43,000 youth in a single month. So we anticipate our numbers for this year will probably surpass what we saw in 2022. And then even as recently as the beginning of May, we have over 18,000 children who are receiving care management services, and this is the highest number that we have ever seen. The one area where we have seen a slight decline in demand has been in our residential services. And this was a trend that we were seeing for several years before the pandemic, as the system of care has grown and expanded and has been able to really develop that in-community service delivery system. We're seeing less and less of a need for children with lower acuity needs to go into a residential or an out-of-home treatment setting. We had about 2,000 youth in 2019 who were in need of out-of-home care. As of now, that number is about 1,500. But what we're seeing is that the youth who are in need of residential care are youth who have those higher acuity needs. So the severity is also increasing.
Okay. And I know it seemed like we were on a stretch there where it seemed like every month was the highest month of services that we'd ever provided through CSOC. I remember that being like, okay, this is the highest number we've ever served through the system of care. Hold my coffee because.
Well, that is true. Like, we saw the beginning of that surge in the late winter, early spring of 2021. And for a variety of reasons, that late winter, early spring is where we typically see a surge in demand. So there are seasonal trends and, increase or decline. We see a lower demand in the summer months. We saw the highest numbers we'd ever seen in March of 2021, but we surpassed that in 2022 of this year.
Yeah. So I think those are really challenging numbers, as we think about how the system is stretched to provide services for youth and young adults that are in need. But I'm wondering if there's anything specific that we can talk about the suicide rates. I know New Jersey historically has a lower suicide rate than the national average, but I'm wondering if we're also seeing an increase, because I think nationally we're seeing an increase in suicide.
So that's correct. New Jersey has for quite some time had a rate overall of youth suicides, which is lower than the national average. However, when we look at the rates for children of color, we see that they're at least 2 times the rate that we see for white children. There's also a lot of concern about the rates of suicide attempt or completions among LGBTQI youth, particularly transgendered youth. It's very difficult for us to capture that because the data reporting and collection systems don't really collect that information as part of the demographic data set. And so we did see, in 2019, our rate was absolutely lower. And we still also see nationally and in New Jersey that the rates of completion are higher with young men than they are with young women, but we see the rates of attempts with young women increasing.
So the discrepancy in completions versus attempts, does that have anything to do with the, I want to say trends in like demographic differences as far as like the options that are being used, or is there something else kind of going on there?
Well, that is one of the factors. And boys and men are more likely to use more lethal means. One of the reasons that we believe one of our rates is lower is because of the very strict gun laws in New Jersey. Okay. But we do see that boys and men are more likely to use firearms. Other methods that can be just as dangerous can also that are used by both boys and girls. But we think that that's one of the things that's attributable to that.
Yeah. Going back to what you were saying about the rate of suicide being higher among Black children versus white children, and also LGBTQ children versus cisgendered hetero children. I'm wondering if, and I think this kind of dovetails into what we were talking about the pandemic and the increase in sort of the services that we're providing as a system to youth. I'm wondering if the increase is attributable to the pandemic, or are there other things going on here in New Jersey or throughout the country that may be contributing to sort of increases in mental health, increases in concerns around suicide? Are there other factors that we really kind of need to consider?
There absolutely are factors we need to consider. Sure. And one of the challenges when we're looking at suicide data is that, thankfully, the numbers are low. Now, even one death is not acceptable.
Absolutely.
But using those smaller numbers to project trends or to make a lot of draw a lot of conclusions about what that says about youth mental health overall doesn't really tell us the full picture. So, for example, we know that the number of youth who in New Jersey who died by suicide actually decreased from 2017 to 2020. Some of the very preliminary data we have for 2021 and 22 shows an increase in deaths by suicide. However, the increase is not as high as the number of suicides that we saw in 2017 or 2018. And so, again, these are smaller numbers, and so any change in a rate could be a very small number, but a very significant rate change.
Sure.
What we really want to focus on, and we do this in a number of areas throughout the children's system of care, and we're doing some work in the community as well, is really focusing our attention on what we can do to really identify and prevent and intervene with youth suicide. So I'll say something else about that, but really to go back to your preliminary question, we know, obviously, the isolation, the uncertainty, the economic uncertainty, the fear of and the experience of illness, children who lost, parents, family members, members of the community. We know that, again, I don't want to associate this with, directly with the suicide rates, but we can certainly understand that some of the communities, not just in New Jersey, but around the country that were most heavily impacted by the pandemic, both in the rates of illness, the death rates, as well as some of the economic impacts, were in communities that were already at risk. So when we look at and we consider both the social determinants of health and how those impact the lives of children and their families and communities, coupled with the effects of the pandemic, I think it becomes kind of obvious that we would see an increase in those social factors, which really are really risk factors for an increase or an elevated risk, not just of suicide per se, but of any other mental health conditions.
Yeah, I want to pivot a little bit because when we're talking about mental health needs and feelings of hopelessness and suicide, it can be a really heavy topic. So I do want to talk a little bit about the services that are available to help. You really kind of keep it more hopeful. But looking at the children's system of care, wondering if you can talk a little bit about the path to services for children in need. Who can make that phone call when there is a need for assistance through the children's system of care?
So I'm happy to talk about that. Sure. So as we said, we are the public behavioral health system. What that means is that we're accessible and available to all residents of New Jersey, regardless of their ability to pay. And I think it's really important that that be known and that information is shared more widely, because I think a lot of folks don't know or understand that that's what the state really makes available through our very robust system. And so really the family, let me just say this. When we talk about behavioral health and mental health needs, and as you shared, we're looking at a continuum, right? There are youth who are feeling sad, lonely, isolated, and we are concerned about that. Those children are not necessarily meeting diagnostic criteria for a mental health condition, but when children are beginning to show those symptoms and signs that they're struggling, that's an opportunity for some earlier intervention or prevention. When children have maybe progressed down that continuum, we may need to look at the need for higher acuity services. We always want children to receive the least restrictive services in the least restrictive setting to meet their needs. And so we've been able, over the last 20 years in the system of care, we've built a remarkable system of community supports and services. And one of the strengths of our system that in part is made available because of the way that New Jersey government is structured and at the state and at the county level, is that we have a system that is led by the department at the state level, but that relies heavily on our community systems and our community partners to really be able to work with families and children in the community and connect them to those services that are in the community that sometimes we don't know about at the state level. And so, we cover a lot of services, that we provide a lot of services that are not reimbursed by commercial insurance. Often families may come to CSOC for services after they've exhausted those benefits, or they found that those services are not really meeting their child's needs. So many people have heard of Perform Care. Perform Care is our contracted systems administrator, and they are the front door to our services. Parents and caregivers can contact Perform Care 24 hours a day, 7 days a week, 365 days a year. The toll-free number is 1-877-652-7624 to request services. And I think it's really important to note, like, families don't need to know what they need, right? Like, the part of the role of the Perform Care member services team is to help connect them to what is going to best suit their needs, whether that be, a referral to a community outpatient provider or a request for a dispatch of mobile services into the community.
Okay.
So typically, youth who are going to come in and receive services through CSOC will come in through either a mobile response and stabilization services dispatch to their home, or through an initial assessment by an assessor who will come to the home, within a week or two from the time that call has made, depending on where you are and what the availability is for that assessor in that community. Mobile response is in so many ways the cornerstone of our system, and we've had many states have come to New Jersey and approached us to ask for technical assistance to understand how to set up this infrastructure and create this within their own systems. And so mobile dispatch is a service. Mobile response and stabilization services are able to dispatch to the home to be available within 1 hour, or if the family wishes, if the family wants services within an hour, the goal is to get out there within an hour, but a family can also request services be delayed for a few hours or until the next day, depending on their circumstances. And mobile provides some short-term, ongoing stabilization services and crisis planning, or they may, depending on their assessment by the mobile response worker, they may request authorization for intensive and community services for that youth, or they may recommend a referral directly to care management services, depending upon what that child's needs are.
So the mobile response is really if the child is experiencing, a crisis moment.
Yeah, and it's really important for us to be clear about what we mean by crisis. Mm-hmm. And so, one of the big concerns that we have right now, and it's not just for New Jersey, is that there's a perception and some data to suggest that there has been an increase in a demand for services in emergency rooms and in emergency departments. And I think it's important when we're thinking about what that looked like both before the pandemic and now. It's not a new issue, but it's been exacerbated by the pandemic. And that we sometimes see that children are they're reaching out for those services, and often the children if parents don't know where else to go, they may go to the emergency room. Many children are very well served by mobile response in the community and in their home. Of the calls that come in to Perform Care requesting those crisis services, only about 1% of those calls are triaged or directed to psychiatric emergency screening. And so it really prevents that out-of-home episode in an emergency room, and really begins to initiate services in the home as quickly as possible.
Okay, that's great. And in the intro, I spoke a little bit about the investment that we've made in this administration into modernizing the children's system of care. I think it was the first investment in 15 years. Was that in increasing rates for providers?
Yes.
Yeah.
Yes.
So I know that happened at a time when state departments across state government were really asked to reduce funding, maybe to some really valuable programming, but specifically to address a budget shortfall. We're not in that position anymore as a state government, so that's a good thing. But I'm wondering if you think that investment was sufficient to meet the needs of the system of care. And I know that's kind of a loaded question, so.
I think that we were really fortunate that those reductions in fiscal year 2021 did not impact the children's system of care. And in fact, we were able to raise the rates for most of our services by about 20% effective January 1st of 2021. Without that increase, many of us think that the system might have collapsed or imploded because the rates had not kept up with cost of living, inflation for many years. And we're competing, our services are delivered by contracted providers, and we're competing with other employers in the behavioral health environment.
Sure.
And being able to really recruit and retain that really seasoned staff is challenging. And compensation is a big piece of that picture.
Yeah.
And so we were really excited to have that increase in 2021. And then following that very shortly, since January of that year, we have also seen the consumer price index has increased by more than 15%. This has had a significant impact on our system of care providers as the rise in costs that are concurrent with that increased demand for services is happening at the same time that we're seeing workforce challenges in the system.
Yeah.
So fortunately, the governor's proposed budget for fiscal year 2024, so in a few months, includes $40 million in funding for contracted DCF services, including an adjustment for CSOC services. And we believe that this funding is critical to sustaining our service infrastructure and ensuring that DCF providers are able to compete for workforce, for workers in this very tight labor market.
Yeah. Yeah. And I think as we, systems around the country are dealing with the workforce challenges. And I think that, based on that forward thinking investment that we had early on, we were maybe in a better position than some, but I know that this is going to continue to be a challenge.
It will continue to be a challenge. Having said that, New Jersey's system of care continues to be held up as an example and a model for other states to implement and follow.
Yeah. So I know how the services are structured, but I'm wondering if we can talk a little bit about the care management organizations and how that's sort of organized throughout the state to best support families and children in need.
So I would describe the organization of the system of care as having a very elegant design. In that it's as I said earlier, we are led at the state level, but services are implemented in the community by our community partners. So the system of care is organized into 15 service areas, which are aligned with the court vicinages throughout the state. That was very intentional to the original structure of the system to assure that we would be able to build those seamless connections and coordination of care, particularly for youth with multi-system involvement. And each service area is supported by a mobile response and a crisis stabilization provider. So just as an example, we have 15 mobile provider organizations across the state serving the service areas, but the requests for mobile come into that single point of contact with Perform Care, and then they're able to coordinate that dispatch.
Okay.
And then each of those 15 designated service areas has a care management organization, or you'll often hear the expression CMO. So the CMOs have a very, very unique role, and they are contracted. They're contracted agencies that provide only one single service line, which is that care management, so that it really prevents an appearance of conflict of interest. So they're not a clinical service provider, but they're managing the care. Most of us are in a managed behavioral health plan, and typically managed behavioral health care includes a care management component. That's typically performed, although not always, by individuals at a remote location. It's telephonic, maybe through virtual means. Our care managers are in the community, they work in the community, and they are a part of that community. They meet with families face-to-face. They utilize what's called the wraparound model to engage their youth and families in understanding what the family sees as their strengths and needs and the child's strengths and needs, and that informs the work of the child and family team. So each family works with the care management organization to create their family team, which includes individuals in their support network. It could include, a trusted teacher from the school. It could include another relative. Could include other folks that are working with that child, and that family decides who they want in their team.
Yeah. And so I know that, because you said something about bringing, a lot of the conversation was around how do we bring in the family team? How do we connect to the family? We're not talking about individual children or, their specific needs, although we're addressing those needs, but we're really looking at how do we support the entire family. So I'm wondering if you can talk a little bit about the support that's provided to the whole family unit.
That's a great question. And so that wraparound model is really focused on developing an individual support plan for the child, but no support plan for a child doesn't include the participation and the efforts of the parents, who also often by the time families get to the children's system of care, they're exhausted. We're typically not the first place that families are coming. And so we have, in addition to our care management organizations, we have our family support organizations. And they provide peer support for families as well as some services for youth as well. They are and can be a member of the child and family team and provide additional one-to-one or group services for families who are involved with the CMO, as well as a very broad array of services for their individual communities. And their offerings and their programming are really tailored to the communities in which they live. Another really important role of the care management organization is that in working with the family and identifying what services they think may be helpful to the family, they don't make those decisions in the child and family team. The recommendations are made by the child and family team. And then the care management organization, the care manager, is responsible for working with Perform Care to ensure that their identified services are clinically appropriate and to prior authorize those services. And so all of that is managed by the care manager, not by the family. Yeah. And so we have developed a very broad array of in-home and residential treatment services for youth with behavioral health needs, for youth with substance use disorders, and for youth with intellectual and developmental disabilities. And in addition to that 24/7 number I mentioned, I always encourage parents, educators, others who are interested in learning more about the system of care to visit the Perform Care website. Very easy. If you Google Perform Care New Jersey, it will come up. There's a wealth of information that we've made available there for providers, families, educators, and the general public. We really strive for transparency and accessibility of information for families who are new to CSOC and for families who may have been engaged for some time. And again, they're available 24/7 to answer questions.
Yeah. Now, something you had said when we were talking about the care management organizations, that they're organized along these 15 vicinages, the court vicinages. And that got me thinking about the proposal that's out there around NJ4S. So I'm wondering, how does CSOC work collaboratively with programs like NJ4S, with prevention supports that are available through other parts of the department or even outside of the department? We talked a little bit about working collaboratively with community organizations, but wondering how we kind of leverage this to be sort of an all-encompassing, all-focused system of care.
So I'm very excited, and I think all of us within CSOC are really excited about the advent of NJ4S. As we know, it's designed to align with those 15 service areas, and this is really significant. It creates the most intentional strategic opportunity to build a full continuum of prevention, intervention, and higher intensity services within each of our community service areas. And within the context of the existing youth mental health community-based planning and service delivery systems. And again, CSOC and NJ4S are administered at the state level, but will be implemented at the local level by our system provider partners, including our county interagency coordinating councils. And so our our kayaks. I'm sorry, we're full of acronyms.
Yeah, lots of
Our
acronyms
county
in
interagency
DCF.
coordinating councils, or our kayaks. And so our kayaks over many years have already developed some work around educational advocacy, and there's an educational partnership committee within each of our kayaks, and there already is an expectation built into the design of NJ4S that they will be partnering and participating in those kayaks. And that's really where those local providers and planners come together, and the coordination and management of that local system happens. So it's going to be I believe it will be mutually reinforcing and of mutual benefit.
Yeah.
As we really begin to build those connections, because the best thing for children is to have their needs identified as early as possible, and to receive interventions and supports to identify what are those risk factors in that child's life, how can we mitigate those, what are the preventive factors and supports that we can bring in to in the best case scenario, either prevent the need for a child to receive higher intensity and more complex services, or to reduce the need for that child to be engaged over a longer period of time.
Yeah, and it's really about building sort of a whole seamless system.
Yes.
Yeah. You had mentioned when we talked about Perform Care, and actually the work of the Children's System of Care is really focused around three main areas. It's the emotional and behavioral health of youth and young adults and children. It's the focus on substance use recovery and addiction recovery for youth, and it's also services for children with intellectual and developmental disabilities. I'm wondering if on those last two, because we've been really focused on the behavioral and emotional health needs of New Jersey's young people, I'm wondering on those last two, are we seeing any increase in need for services related to substance use treatment or for children with intellectual and developmental disabilities?
So there's some interesting dynamics around the demand for substance use disorder services for youth. We see a decline in demand for our services based on utilization data, and again, that predated the pandemic. I have for some time, I believe that this has really been an effect in some ways of some other positive developments. And so until the passage of parity and the Affordability and Accountability Act, around 2014, 2015, there were a lot of limits as to what commercial payers would reimburse for substance use disorder treatment. We've now, since then, we've seen parity requiring that there be parity of the behavioral health and physical health benefits in New Jersey. New Jersey's been extremely progressive. We have a very rich, robust array of substance use disorder treatment services that are reimbursed by our Medicaid state plan. But there are still unmet needs. And, we know during the pandemic, there were a lot of reports of increased, alcohol use among adults. There's no reason to believe that children were not also self-medicating. And I think it's certainly important when we see children beginning to use substances to really understand what's driving that use of the substance. It could be recreational, but more often than not, when we see it becoming problematic, it's also an effort on the part of that child to manage and self-regulate. And so when we think about what children were experiencing during the pandemic and their families, we do think that there has been somewhat of an increase. It's also, and that we're seeing now too, is that the issues that we're seeing are more significant. And it's challenging to find treatment providers who can treat youth with co-occurring substance use disorders and mental health needs, which is critically important for children at this age. Because there are many youth who maybe meet criteria for substance misuse, but may also have a diagnosis of depression or anxiety, and those things are mutually reinforcing. And so understanding how youth are using substances to self-regulate and why is really important to their treatment. So having that ability to work with both substance use experts and mental health clinicians is really important. Another big factor was that during the pandemic, the legalization of cannabis in New Jersey, we do believe has had an impact on the number of youth who are coming into care because we often saw that one of the drivers of children being identified and referred into care was around youth arrest for substance use, which was really a big driver of entry into treatment services. And so with the other changes we've seen in, though it is still illegal for children under 21 to be using cannabis, the law enforcement response to that is different. And so we're seeing that decline. Another thing I want to really illuminate is that while we don't see a significant number of youth coming into our system with opioid use disorders, we know that among individuals who die from an opioid overdose, young adults are overrepresented in that cohort. So we really need to emphasize prevention and harm reduction with children and to make sure that they understand those risks. So we're really concerned about what's happening in those years. And we've begun for children who are being discharged from our residential programs, residential substance use programs, regardless of their diagnosis, we are providing them with Narcan so that they have that understanding and knowledge of how important that can be to save lives, if not their own, perhaps that of a friend, and to really provide that education.
Yeah.
So, our youth with intellectual and developmental disabilities were profoundly impacted by the pandemic. We do have anecdotal information that depending on where a child lived and what supports they were receiving in school, there were many teachers who really were heroic during the pandemic and found different ways to ensure that children were having their educational needs met in the home while their parents were also grappling with what it meant to be in shutdown. But then there were many children who we believe didn't really have the full benefit of their educational program for obvious reasons. And we also need to remember that children with intellectual and developmental disabilities have an elevated likelihood of having a co-occurring medical vulnerability. And so the pandemic and the concerns about exposure to COVID, while we saw a decline in all of our service lines, we saw an extreme decline in some of our services for children with intellectual and developmental disabilities. Some of that was clinicians not feeling safe going into the home, but a lot of it was also families not feeling safe. And so the shift to telehealth was critically important, but we think that for many families and children, like telehealth is not as effective. There are certain interventions, particularly with behavioral interventions, that are going to be more effective when they're being implemented face-to-face. We've done, and we understand that the sort of cumulative and protracted effects of the pandemic are persisting. We've seen an increase in the number of youth with higher acuity needs and an elevated number of children who are requiring residential crisis services than we had seen pre-pandemic. We've sought to increase our provider network capacity for in-home services in the wake of the pandemic. We've issued a number of requests for qualifications to build our intensive in-home treatment services for children with intellectual and developmental disabilities, our residential service capacity, and we just launched a pilot program to deliver what we call a sort of a residential care level of intensity or like intensity of services that you would find in a residential setting in the home and in the community. And so we think that this model, it's a pilot, we will be evaluating it, but we're hopeful and optimistic that that this model can serve as really as a model for other levels of care and other services.
Sure. Yeah. And I think when we talk about sort of trying to meet the needs of youth at the lowest acuity possible, where we want to make sure that it's the setting is appropriate to their medical needs, as we start to think about more in-home supports that we can provide that meet those acuity of needs, I think it allows for children and youth to have better outcomes, right?
It allows for better outcomes, and it also eliminates two of the biggest challenges. One is that when a child leaves their home for treatment, they're leaving their home and they're leaving their family. And that in and of itself is disruptive, traumatic, And, living in a residential program, although the majority of our programs are very small, community-based, home-like settings, it's not the same thing as living in your family's home.
Sure.
And then the other challenge is when it's time to transition home, being able to transfer the skills and the new behaviors and skills that were learned in the residential setting into home can be very, very challenging. And so eliminating the need to go out of home at all really prevents those issues from occurring for a family.
Great. I want to switch again back to the work that CSOC's doing around suicide prevention and the Zero Suicide Initiative. I'm wondering if you can talk a little bit about what is Zero Suicide and what are our hopes for this initiative?
So Zero Suicide is a transformational framework for health and behavioral healthcare systems. It's a model for organizational change and attention to preventing suicides and making changes throughout the organization to support identification and reduction in attempts and completions. So for systems that are really dedicated to improving individual safety, it's a practical framework as well as an aspirational challenge, if you will, for system-wide transformation. And it is an evidence-based approach. And so we have partnered with the Zero Suicide Institute at the Educational Development Center to implement the Zero Suicide Prevention model with a number of our provider agencies. So this is something that is, because this is one of the benefits of managing this statewide system, is that we're really in a strong position to implement this throughout our agencies without our agencies having to go out and sort of find this on their own. And so it's a system-wide effort. Yeah. So we started last year implementing this within our care management and our family support organizations, and then some of our residential programs as well. In year 2, we will be including our mobile response providers and some of our additional out-of-home programs. So what this looks like for the agencies is that they create what's called a Zero Suicide team within the organization that includes leadership as well as direct care staff, quality staff, and persons who have lived experience. So with the support of the Educational Development Center, each agency creates a work plan for their organization that emphasizes their implementation of the 7 elements of the Zero Suicide model, which include leading, training, identification, engagement, transition, training, and improving care. And then they also have an opportunity to participate in a monthly community of practice meetings. So there's a community in which they're learning from each other as well. And there also are subject matter experts and resources available outside of that learning community throughout the model. And, we started this at a time where we were really concerned. Over the last year, as we began to see the surge, we were really concerned about the anticipated increase in suicidality. And so we tried to be as proactive as we could to address this within the system of care organizations so that we could implement that with the children who are under our care. We're also working with the Department of Health through the Garrett Lee Smith Grant. We've launched what we call Project Connect. Really excited about this initiative because it's really simple in a way. We know that 50% of children who presented in ED are likely to come back within a period of several months. Mm-hmm. And so through Project Connect, we're going to be training and educating emergency room staff on how to engage and connect parents with the children's system of care, which could, in the best case, include a warm handoff from the emergency room to perform care and a request for mobile dispatch even before that child leaves the hospital. And we think that this is a really critically important way to make sure that that family has a connection and that child has access to a service immediately post-discharge. And we will have a care coordinator who will be following up with families to ensure that they've been able to connect to services.
That's great. And I think when we think about suicidality, it really grows in the dark, right? It when we have sort of a system-wide approach like this, where we have every facet of the children's system of care that's going to be coming online with Zero Suicide, and with Project Connect and making sure that families know that there are supports out there, I think that really is going to make a great impact. So thank you for that. So finally, I just want to ask this one final question. From your position as the Assistant Commissioner of the Children's System of Care, beyond funding, what's one thing that you think the system needs?
It's really hard to think of a single thing, and it's really hard to think about that outside of funding.
Mm-hmm.
I do think that what we most need is to move forward with a laser focus on prevention. And some of that work doesn't sit in the system of care. It sits in the systems that we're adjacent to, but we have a responsibility and a role in supporting that work. And really illuminating and elevating the importance of early identification, routine screening, early identification, and engagement with services, appropriate services earlier on when a child is experiencing challenges.
Yeah.
So a lot of that has to do with, integrating screening into our primary care settings, and also making sure that, pediatricians and other healthcare providers know how to respond. And so getting more information out, spreading the word about the system of care, what's available, so that, healthcare providers have somewhere to refer families to.
Yeah, and I think as we think about that, it really is about allowing the system of care to be that system of care, exactly that. It's really about how do we grow it in such a way that, physicians feel like they're a part of it. Schools feel like they're a part of it. Families are a part of it. Like, how do we do it in that way? So I think that definitely kind of resonates. So thank you so much. Thank you so much, Mollie, for taking the time to be here. Thank you to your team, because I know that this work is really difficult work, but it's so necessary. It's such a big part of how do we keep families in New Jersey safe, healthy, and connected. It goes back to our vision and mission. So thank you.
Thank you.
Next month, we'll hear a little bit about what DCF is doing to connect the prevention services array in New Jersey to national efforts through the Federal Family First Act. So until then, and on behalf of my producers and the Office of Communications and Public Affairs here at DCF, this is Jason Bukowski signing off. Tune in next month for more DCF on the Air.